If you are a clinician and you would like CME from this activity, the person to contact is Lynn, SCHWABEL at ohsu.edu, and she will set you up. Today's presentation is going to be about lessons learned from the AMIA meeting, and the presenters are Anirudh Chintalapani, Theodore Wright, and Inho Kim, who are ACGME fellows in clinical informatics, and Erin Hickman, who's an NLM fellow at clinical informatics. And so without further ado, I will turn the floor over.
Okay. So hello guys, thanks for coming. I'm Brady Wright, and so to start, we're going to give about a 10-minute presentation each on what we all learned, and then we'd like you to save questions for the end. So I'll just get started. Disclaimer, nobody had any commercial interest in any of these presentations. So one of the things I learned is Chicago. It was not my first trip, but my first real stay there. Has the worst Uber cab drivers I've ever seen. It's kind of expensive, but it is a really beautiful city. I highly recommend going back. So the way I took the AMIA conference was I wanted to explore. I'm relatively new in informatics, so I really wanted to see what's out there. So I focused on going to demos rather than more advanced research. One of the more interesting demos, I guess organizations that gave multiple demos, was the National Library of Medicine, which you all are familiar with. Clem McDonald is an amazing person, more energy than I'll probably ever have. But he went over at least 3 things that I'll talk about. One was RxNorm, which is a drug database. The other one is Clinical Table Search Service, and it all kind of ties together with their LHC forms. The RxNorm is, like I said, it's a web, well, it's a database of, it's a collection of databases of a lot of drug information, really useful. The primary way to access it is their RxNav website. It's a web-based browser. It can display everything from drugs, dosages, formulations. It has both generic and brand name lookups. You just simply type in the search box at the bottom, and you can get a lot of good information right there on the home page. It can also do some more advanced things like map relationships from, for example, mesh tables. Like here on the right, I have omeprazole is mapped to mesh terms. It's a proton pump inhibitor. You can manipulate that map actually right there on the website. And it can do also like physiologic mechanisms of action, and it's a really, really neat service. It has a service that can do pill images, and you have to give it a specific dosage type to get the pill images. And then lastly, it can do drug interactions and list those for you, and you're able to get that straight from the database. The really cool thing about the RxNorm is that it has an API, so a program interface, and it's built on this RESTful application, so you can just do it straight in HTTP. And there's the prescribable one, which filters out only, and it focuses on the U.S. prescribable information. There's RxTerms. It's linked to the VA's NDF database, which has most of the interactions in it. And then it actually has the RxImage API. So the cool thing about that is you can use it in your own applications. You don't have to start from scratch and build your own drug database or buy some expensive drug database. You can rely on them to provide the underlying database for a really robust clinical application. This is just an example of one of the cooler things I thought was the spelling suggestions for drug names. So if you typed in omeprazole, which is something patients like to call omeprazole for some reason, then it'll actually return suggestions for similar matching names. Then the next thing that they talked about was Clinical Table Search Service. This is a backend, and it's another API. And it enables you to easily query other databases such as ICD-10 codes, RxTerms, drug ingredients, the LOINC forms, genes, alleles, SNPs. I think there's 10 or 12 databases total. You can really quickly, you can see with that small amount of code, come up with a box or something that you can type in jet engine for whatever reason sucked into jet engine, subsequent encounter. So you can build that very, very quickly and again use what they've done. They've done all the legwork and they maintain these databases for you. And then I tie it all together with what they've created is called LHC Forms, and it's a widget toolkit, so you can build widgets. And it uses the clinical tools search service and Logic Forms, and it's written entirely in JavaScript and AngularJS framework, so you can build widgets that do clinical entry, basically, and the underlying mechanisms are, like you've seen, already built. Like here's an example of the PHQ-9, the panel, which is really quick to build. So another interesting talk I went to was from the VA. They always like to show off their new tech, and their newest and coolest tech that I've seen was their new next generation EHR, which is called the Electronic Health Management Platform, or EHMP for short. Jonathan Nebeker showed this off. What this specific demo was about was the novel features for what they call activity management and notifications, basically a task manager. But it was pretty cool. So the EHMP is still under pretty heavy development. They just came out with version 2.0, which has enabled the write functions, so they can actually write back to the database. Again, it's built partially using JSON and also uses FHIR interfaces, and it's essentially completely widget-based. So that's kind of why I wanted to add this in here on top of the other things. It could be a platform for building widgets that we could build and apply and use this platform being built on FHIR interfaces and with JSON. It could all work together. Specifically, their activity management service was pretty cool because they designed it in such a way to where you can, for example, if you put in a consult for pulmonology, then that consult will be tasked to go to some pulmonologist. You don't have to specify what pulmonologist or where. It just goes to that specific pulmonologist. Or if you want to ask their primary care to follow up on a lab you've ordered in the hospital, you just have to say follow up primary care. Then the system actually manages that in the back end and will either send it to primary care, or if that fails, it'll send it back to you. It's a pretty robust system that they've implemented and are trying to pull at the VA. So, all right, so I'll spend my time. I'm going to hand it off to Dr. Chintalapani.
All right. So, what I learned at AMIA, a couple things, and first off, I learned that one of the best and worst things about AMIA is there's so much there that oftentimes all the things you want to see happen at exactly the same time, so you can never really see everything. I also learned get a hotel at AMIA because my parents lived there, so I had to drive every day, which was a nice hour drive back and forth, but that was fun. But what I wanted to get out of AMIA was really to look at the things that I'm interested in, the things that affect me, and then also kind of go beyond my own scope and kind of learn about things that I may not know much about or may not be as knowledgeable about, but it certainly seemed interesting and things that I think are important. So there are 3 things that I learned that I'm going to share with everybody today. The first one kind of relates to personal interest of mine, which is being a clinician, being someone who interacted with EHRs very much on a front-end level. Usability is something that has I certainly have a great deal of interest in. And so one of the presentations that I went to that I found pretty interesting for several reasons, namely that the presentation was focused on usability, but actually a lot of the questions were directed at the application itself. And it was the usability of an automated reminder system for clinical order entry. So the way the presentation worked, it was that it was focused on the usability of a CPOE clinical decision support system that would offer providers a recommendation of orders based on the diagnosis code. Now, how that recommendation would be done was that it would function similar to the Amazon product algorithm of customers who bought this product also bought this feature. By showing orders that other providers entered for the exact same diagnosis. And it showed it based on their frequency. So for example, if you entered an order of sepsis and you were treating someone with an ICD-9 code of sepsis, it would look at all the other providers who was treating someone for sepsis and look at all the different orders that they had put in, labs, medications, and then it would display that information to you in a clinical decision support system and show you what the other providers had entered. And that was kind of the system that they were showing off. Now, mainly the talk focused a lot of it on the usability of it, but I thought it was interesting also kind of and why it was being designed, because this CDS kind of stood in contrast to human authored order sets, which is what we do now. We typically have a small group of people designing these order sets based on the guidelines of based on guidelines and based on recommendations, and this is trying another approach at it and determining its validity. And they did a study that said that it is as effective, and I apologize, I don't have the paper with me. And like I said, he was trying to focus mainly on usability, but couldn't really get there because I think people were more interested in that. So some of the things from a usability standpoint that I found that was interesting is that physicians typically don't think in terms of numbers of what people order the most. So when they say PPV, that positive predictive value, that's showing how many other physicians ordered the exact same thing. So if you had a PPV of 99% of sepsis, or if it was sepsis and say a antibiotic such as like vancomycin, that would be 99%, meaning that 99% of physicians would order this medication if they were treating someone for sepsis. So that's kind of how it was. But physicians, when they were interacting with the system, they didn't like this and to show it in numbers. They typically think in terms of groupings, meds, labs, orders, things like that. And so that was things that they had to rearrange. And also showing things like PPV, relative risk, and these kind of different variables was too much information, which is another kind of common usability theme that we think about. Don't show people more information than they need, only show them what's relevant to their to them at the time that they need it. So these were all kind of usability lessons that I took away from it to kind of, in the future, if I ever want to kind of work on usability projects and usability studies, things to think about. So I took this from AMIA's booklet. They had a PDF that kind of showed off a lot of their, or had summaries and abstracts for their papers, and he managed to show an image. I know it's very blurry, I do apologize for that, but basically on the left side, this was a kind of a homegrown system that he showed, and this was the HMP at the top where you showed the orders, and based on that, this was the clinical decision support system that was displayed to the user. And again, like I said, kind of showing the different levels of percentages of how people did it. And this was after the redesign where he kind of categorized them into labs, meds, and microbiology, things like that. The second one is one that I think has affected me as a clinician, and it's something that I deal with a lot, and you know, we've talked about this, which is problem lists and how we maintain problem lists, and has been a great deal of issue for clinicians because personally, I know that we don't maintain it that well. Oftentimes, you'll see a lot of patients with multiple problems that are the exact same thing being written multiple times. You see problem lists that are not being updated. And so that certainly creates a problem for physicians because it creates a system that's not exactly very usable. And so one of the other demos that I saw that I thought was quite interesting was Intelligent Medical Objects, and they were a company that's trying to come up with a solution. And their core function was to simplify the coding process and bridge that gap between coding systems and medical terminology. So what they would do is they would take multiple lists, or multiple problem lists in ICD-9 and ICD-10 codes, and they would try to group them together into more clinically relevant groupings. So instead of having CHF, systolic heart failure, diastolic heart failure, and having 5 different things at the same time, they would take that into one category of cardiovascular disease and group that together. And into heart failure with, you know, whatever grouping that they would list. To basically take those kind of convoluted ICD-9 and 10 codes and group them into more clinically relevant terminology that physicians can use and has more value for the physicians. So I think that was interesting to me because I think it works to kind of serve that gap and bridge that gap at this point. Dr. Kim is going to kind of, talk a little bit more about problem lists and some of the other talks that we went to that kind of address problem lists as well, and he has some other topics there, so I'm not going to go too much, but this was, I think, interesting in terms of visualization of that data and how we group it together and how we present it to the physician. And then the last one is one that I think was very much a hot topic at AMIA, which was FHIR and then Smart on FHIR, and using that. And then one of the topics that I went to that I thought was pretty interesting was how do we present that information? How do we get the app to the clinician at the point of care? Because as the system, as it currently exists in the system right now, for a smart app, if you want to run a smart app on Epic using the FHIR standard, you would have to run that app simultaneously with the EHR at the same time. And that can be very cumbersome because if you have 5 different smart apps that you want to run, you would have to run all 5 at the same time or run them when you need them, and you'd have to know when you would need them. And that can be very cumbersome and can make it very difficult to use. So one of the things for the group that is designing the smart apps that they want to kind of put in place so that these apps can be run automatically at the point of care was something called a CDS hook. And a CDS hook is simply a system where the EHR vendor would allow for a call to an app to be triggered based on a specific user action or a trigger point. So if you try and enter a specific order or a specific med, or you reach a certain point in your workflow, that would trigger a certain smart app to be used. And I think that's very important. I think that's very useful as we talk about SMART and FHIR and all these different apps that come out. I think one of the important things is to make sure that these apps become triggered at the point of care rather than expecting physicians to know all the apps that exist out there. It can pull those apps and call the apps that we need at the time that we need it. So I found that topic or that presentation was very interesting. With that, I will turn it over to Dr. Kim.
Hi, I'm Inho. So stuff that I'm going to talk about is problem lists and workflow. There's the majority of the 2 topics that I found interesting. And so part of the reason why problem lists were at a lot of the talks at AMIA is that there is no single standard definition. One of the kind of general definitions that people have, it's a list used within health records, usually with illnesses, injuries, other factors that can affect the health of an individual patient. There's multiple definitions from meaningful use, stage 1, joint commission, HL7, and just to give you kind of an idea of how different those definitions are. Meaningful uses, stage 1 definitions, maintain an up-to-date problem list of current and active diagnoses based on ICD-9 or SNOMED for 80% of patients, 80% of the time, and it has to have at least one coded problem as opposed to the entire problem list coded. Joint Commission's definition is any significant medical diagnosis and conditions, any significant operative, invasive procedures, adverse allergic drug reactions, any current medications, over-the-counter medications, and herbal preparations. And HL7 has even slightly different one. It may include, but not limited to, chronic conditions, diagnoses, symptoms, functional limitations. Again, that's slightly different from the other 2 definitions. Visit, stay-specific conditions, diagnoses, or symptoms. And so, as you can see, no single standard and can vary even between different national kind of definitions that we have. And so with that, one of the groups, IBM Watson, tried to have a way to better curate the problem list that's relevant to clinicians. Because much of the time problem lists, as Ani was saying, is like has CHF, systolic failure, diastolic failure. It's like overrun with sometimes duplicate problems or problems that aren't relevant to the clinician or provider. And so they tried to set up kind of a test for Watson to see if Watson could supplement clinician use, curation, and thinking in regards to the problem list. Using some NLP, some knowledge-based features, some clinical attributes, and to eventually create models in Watson for what is and what is not a problem. And so how they kind of tested this, the gold standard was the physician. And the physician, 2 physicians would review the charts and then go over to curate what they believed to be the actual problem list. And then it was given a rating for how close it was to what actually should be on the problem list. And so as you can see from the x-axis, that's the rating on the bottom of how high the rating. So further to the right is the better rating. And then the y-axis is the count. So the pink on top from their study was just how the problem list is curated now. The physicians went through the problem list before using Watson or before doing the 2-physician review and saw, how clinically relevant is the problem list. Are there a lot of duplications? Are there not a lot of duplications? And they gave it a rating. And you can see from the standard of care before checking with physicians or before checking with Watson, the ratings are kind of all over the place, and there's lower rating counts, down below. The green is the physician gold standard, and that's very much the right. It's a little bit self-fulfilling prophecy because they're reviewing their own charts. And then the blue is Watson. And basically their kind of criteria was how close is Watson to the green, like how close is the blue to the green, and it's pretty good. IBM and Watson group was saying, like, you know, Watson did a pretty good job with the parsing and the vectors and their kind of algorithm that they used. And then so some kind of, during the discussion in the panel, some things that came up were that some physicians in the audience were worried that the Watson group was trying to supplant provider thinking, and the same person kept arguing about that. And then, but they kind of tried to, I guess, alleviate that by saying that this is really just to catch things that maybe physicians didn't catch. And they acknowledged that Watson did catch a couple of items that should have been on the problem list that weren't on the physician provider's problem list. And even after the physician spent an hour, on average, the physician spent an hour on the chart. So after an hour, there were still a couple of problems that the physicians missed, diagnoses or clinical symptoms that the physicians missed that Watson picked up. And so at the end of the day, the IBM group was trying to say, yes, like, we don't want to supplant physicians, but we want them to have another kind of resource they can use to help curate the problem list, to maybe catch things that they might have missed. So another problem list kind of talk I went to, it was really quick, like 5-minute kind of rapid session talk, was from Dr. Bannon at Cleveland Clinic. And his idea was more kind of a social kind of issue where we have to have a better way of managing problem lists. And to start by doing that, we should teach our medical students better. And how to do this was to make sure that anything that's on the problem list has a plan. That if it doesn't have a plan, it shouldn't be on the problem list and it should be taken off. And like an easy example is if you're admitted for lobar pneumonia and you finish your antibiotic treatment, you should take lobar pneumonia off your problem list, because if you've completed the antibiotics, you will no longer have lobar pneumonia. Whereas if you have chronic knee pain and you still require rehab, it should still be on there. And he even made a point to say, like, if you have prediabetes, you're not on a medication, you maybe don't even have follow-up, but your diet may be slightly different. And so even in that sense, prediabetes can be on your problem list because it has a plan of a diet. And so in that way, to try to be all-inclusive but not have every single little issue be on the problem list. And now some other kind of different talks I went to. So this one kind of talk I went to was on workflow, and it was about trying to standardize workflows and capture that in a standardized fashion so you can know what you're doing and then to see if there's any changes after implementation. And this was done at Arizona State University, which is a Mayo Center, and they were doing a new Epic implementation. And so they were trying to find a way to capture clinical workflows in, again, a standardized fashion. So they had this like kind of chart to basically kind of ask and answer questions of who does what, like basically activities, when, where, and how, basically some sub-activities, if you can think of, like employing which resources or tools. And kind of each blue kind of box is those questions of who, why, what, and the orange is kind of those activities and more details of those. And so they would then take this and have those relevant concepts and try to make activity network diagrams. And again, and through all of this, it's not necessarily always just formal work structures, but also they would combine informal and formal work structures to kind of pull this all together and to have a complete cohesive kind of diagram of the workflow in a standardized fashion, again. So let's see. So as a sample case, they had like, so there's delayed surgeries. And so you have these long cases, and you're trying to make sure that surgeries aren't delayed because of like RN nurses taking too long to do medication reconciliation. And so some of the things that they needed to find for the analysts to create a standardized workflow image or picture was patient and provider-centric activity diagrams, task durations, information needs, and sources of variation. And so this is kind of an example of what they would try to diagram on a bigger level. The blue boxes, you can think of them as activities. And each of those blue hexagons can be further split up into multiple steps of sub-activities. And so they would just continue to break it down until they had every sub-activity and activity kind of fleshed out in a standardized fashion using those questions from the previous blue and orange diagram you saw before. And that would be for RNs, for CRNAs, anesthesiologists, et cetera. And so with the workflow, like this is kind of an example of how they would fill that chart out in a standardized method. And again, this is just a sub-activity of like medication reconciliation. And you can see that it's just like either RN with the patient and to whom is like surgery patient, just filling out every little box to make sure they have it all filled out. And then eventually they take those sub-activities, fill it all out, and then this is how they would kind of capture all that information. And so you can see that do ethnography and observation using Moray video to capture anything, so they, just in case they missed it during just watching in person. They would also take artifacts, and those artifacts being those charts and filling out those charts and those diagrams. And then finally, just in case, have another level of kind of detail to make sure it's some of my standardized capture of workflow. They would take like the timestamp logs to try to have another layer to make sure they're having a standardized way they're capturing the workflow. Thank you.
Thanks. So I'm going to hopefully finish this and won't keep you guys too long. So I went to some sessions on patient portals. One of them was part of the CMIO workshop, and then one of them was just like a standalone session. So these are some things that I learned from those. So just starting out, some of the meaningful use goals for patient care, for patient portals. So one, the first measure is that more than 50% of the unique patients seen by eligible professionals during the EHR reporting period are provided timely access to view, online, download, and transmit. The second one for 2015, 2016 is that at least one patient seen by an eligible professional during the EHR reporting period is able to view or download. But for 2017, they're looking for more than 5% of those unique patients, so it's slowly starting to build up and have more importance in regards to meaningful use. And so somebody had done a study regarding predictors of use with the patient portal. So they found that people with disabilities and chronic diseases were more likely to use them. The healthcare frequent flyers, and then caregivers of the elderly or kids were more likely to use them. Negative predictors were minorities, people over 35, healthy, and then the less educated. And then on the right side, so when you see this dark blue, this was a study done out of Southern California. Somebody had looked at their 5 community hospitals with 13,000 to 60,000 patients. There was 13 clinics within this, and basically what they were trying to see was get a feel for their healthcare system for patient portals. And so when they looked at their system, the things they found regarding why patients weren't using them as frequently were pretty much similar to this other study done somewhere else. So language was a big one, literacy, fear of deportation, so this was seems like an underserved community, and then digital literacy. So what patients say they use patient portals for? So when asked, have you ever used a patient portal? 7% of all adults said so. And then what was most useful about the patient portal? What they said was making sure the information was correct. And so in terms of what the CMIO and what kind of drives patient portals, the thought is there's going to be better medication adherence, better management of the disease, self-management, appointment adherence, but some reasons why people aren't tuned into patient portals. So again, we saw some of the limiting reasons on the last slide. So non-English speakers, pediatrics. So one of the CMIOs was said once the child turns 13 in their system, then they give access to the child. So you can imagine if you have this 14 or 15-year-old who is secretive about their stuff. Maybe mom doesn't know what's going on, but she's going to the appointments. And then the issue of privacy. And then there's this other thing kind of related to patient portals, and that's patient-generated healthcare data. So how they defined it was really health-related data, including health history, symptoms, biometric data, treatment history, lifestyles that are like essentially gathered or inferred from the patient. And one of the talks I had went to, they had like categorized it into different categories. So one was provider generated, patient monitored. So this was what they deemed as like information that or data volunteered by the patient. And then purposely collected data. This was like your smart technology, smart watches. And then volunteered patient advice. So this was how patients interpreted their data. So maybe they didn't bring their smartwatch to the appointment, but they were like, oh, I hit like 75% of my like Apple Watch milestones, whatever that means. And then data collected via third party. So, you know, it was like Twitter or whatever, secretly monitoring every time we search something and then using that without our consent. And then so this chart, so that they asked like physicians in the US and across like the globe what they thought patients should be able to use the portal for. And I'm not sure you can read the first, I'm not sure you can read it, but essentially the green is like all information, like what they believe the patient should be able to do. And the US physicians are on the right, and then on the left column is global. And so the biggest green area is on the bottom, so demographic information. So basically physicians say like, we don't mind if the patient's like putting in demographics, but as you get further up, so the top is lab test results. So maybe you had your test results at hospital A, like they don't care that, they don't want you to bring it to hospital B and like put it in the computer, essentially. So other concerns with these different models, so like if a physician is like hiding notes, so like maybe you do like a psych eval or something and you like hide the note, then like some say it's like disservice to the patient. Patients are like rarely allowed to like generate notes or their own notes. And then with some of the purposely collected data, so like the smartwatches, is it like a lifestyle? Again, like I hit all my Apple milestones versus like it says I walked 3 miles. Accuracy, so if I like ring my arm 100 times, you know, did I walk an extra mile today? And how does that get logged? And then the legal implementations. And kind of what drove like my interest in this patient portal thing. So there was a CMIO from a pediatric center who basically said that they were starting to use their portal for secure messaging. And so they were going to allow time during the day, like block out certain, like an hour in the morning and the afternoon for these outpatient providers to be able to message with their patient. And so the guidelines was the providers would have to return the messages within 24 hours. Patients could send data, for example, like blood glucose values. And then the provider could like sign off on it and it would generate a PDF, which would then be put into the chart. So this like drove a lot of interest. I was like, oh, that's like one like workflow. So that night I actually had dinner with 2 of my like former co-residents. And some of the things that we had come up with during our conversation was, one, they were like, thank goodness I didn't do outpatient, if now I'm going to have to respond to text messages. Added work, like influences on workflow, liability. If like a patient underestimates versus overestimates their symptoms, just like, are they using it for emergency situations? So let's say if somebody sends something on like the first hour and you don't see it until the 23rd and they should be in the hospital because they have like a really high glucose or something. And then going back to the study that I showed you from California, so essentially they created like a patient portal in their hospital. And so when they talked to staff, I thought some of these quotes were interesting. So they said, we stopped other work to get our enrollment numbers. They told staff, try to enroll at every opportunity. We had to set them up with email if there was time. We would teach them how to navigate their inbox. So like the thought is like you generate this patient portal and then you have like more communication with the patient. But like I think a lot of what's like forgotten is the work. And the one that was really sad is this one. It says, we really didn't want all our patients signed up. We just need to reach the 5% requirement. So essentially, while the goal of these like patient portals is to make the patient feel empowered, I think there's some hesitation from physicians and maybe even some patients about like its use. So some of the conclusions were and recommendations were similar to what I had come up with. So basically, not just focusing on meeting the 5% or like the meaningful use requirements, but being able to build a system that is like usable and appealing to all patients. How to do that, I'm not sure, because there's such a discrepancy right now in who uses it and who doesn't. But in talking yesterday when I was giving the practice, one thing Inho had brought up is maybe having some more like clinical decision support feature or some sort of kickback to the patient so that they want to use it, and maybe where it takes some of the burden off the physician. So that is the end of our presentation. If you guys have any questions for anybody, we're ready to hear them.
So I actually meant to ask, I'm curious how many people here actually went to AMIA? Okay, cool. It was fun, wasn't it? So yeah, comments, questions, arguments, criticisms?
This is for the presentation of the CDS recommendation system.
Mm-hmm.
Do you think that there might be any problems that could crop up with a recommendation system that's based on frequently co-purchased items or ordered items?
I think so. I mean, a lot of what they talked about, and I kind of felt bad because I think he was trying to really get at the usability, and he had a study, and I'll be happy to like send anyone a link for where it was. I know I have it somewhere, but I think it's a concern because, you know, is it, and I think even he said, is it the wisdom of the crowd or the mentality of the mob? And it's, if everyone does something, does that mean it's still the right thing to do? I think that was one of the first questions that people brought up, and he spent probably 90% of his talk defending what he was designing, not defending the usability of that design. But I think, you know, as we just had that one talk just recently about the kind of medicine that we do changes a lot, even the guidelines that we follow. So how often are our order sets updated and maintained? And that was kind of his, you know, argument is that, again, if all the physicians are following, in theory, the best practice or the best guidelines, is this an equally valid way of presenting the decision support to the user for what should be ordered for a particular diagnosis? If you follow one, you know, the way we do order sets now, it's a very small group of people that design it based on whatever the clinical guidelines are. And this is kind of taking that other approach to it. You know, I think I had a feeling everyone's like questions would be focused more on the validity of that and its general outcomes. And I think that's, to be honest, I would have to look kind of more into it and to say whether or not that's equally valid or leads to the same outcomes as following a human-authored order set that follows best practice. And so you're right, and I don't know which is, right now I have to kind of look at it to say which is more valid. So, you know, it's a great question, and you know, unfortunately I can't give you the best answer for that. Yes?
Oh, yeah. So they have the what, who knows what, and the different categorizations for the workflow.
Uh-huh.
But I wasn't clear, how do they envision making that actionable or using it to reduce the number of delayed surgeries? Like,
Oh, it wasn't. It was their first, it's like the first step of many steps. It was the first step was like they want to find a baseline. And then if I didn't make that clear, I'm sorry. It was like their part of their kind of panel, like whatever it was, to show how they were creating a standardized method to capture clinical workflows, so that they could then see, is it better or worse, getting better or worse, and have a baseline to then improve upon. Yeah.
to get everybody to do things the same way?
That's why I went, like, I was interested in that talk, but it was more just like how they captured it, so that they could maybe one day do that. Yeah.
Did they have, who was responding? Was it always the provider that responded, or did they have like nurses and other ancillary staff that could respond on behalf of a provider?
Yeah, for this one, they like pretty much were trying to drive it to the provider, but they like basically they were saying they were getting a lot of kickback, so they were going to try to figure out how to put like the nurses in there, but they weren't sure like that's where the level of triage would be at that point.
So my question is also about the portals. I haven't looked at the literature very much, but I know in the portal that we have here, there's pretty clear language that there's certain things you shouldn't be asking, and urgent questions aren't appropriate for that. So, I mean, did they say anything about the design of the portals to the effect of, kind of educating people about what's appropriate to use a portal for?
Yeah, like, so that was like one of the big conversation points in that meeting, and other CMIOs were like, in our hospital, we're a little concerned about doing this for those reasons. And she was like, we're trying to like educate the patients when they sign up, like what to message on. And then they were actually trying to take some of the burden off physicians by having like smart phrases, so that they could like put like if somebody had a cough, they could like smart phrase cough. It seemed a little, to me, it all seemed a little bit dangerous on like the legality of different stuff, but she was confident that they were going to have success with the system.
So kind of on that point, I don't know if people saw, there were some posters on kind of patient-generated data, but I don't know if it was necessarily data. Someone had prototypes of what apps might look like if you had, one was for diabetes, and I know one was for HIV patients, for either side effects they're having or symptoms that they're having. They would have cards of, they were showing patients like what they're feeling or how they're feeling, and then if they felt that, then the app would generate what the patient should be doing. So to kind of like, it's kind of like patient portal, but instead of using the portal, is like self-management, giving the HIV patient a better self-management tool to say, I'm not feeling good, and then being like, that could be a side effect from this medication you're taking, and you should, eat more of whatever, or do this, or exercise, and to kind of have like another layer of, not a layer, but like of self-management for the patient. There was some really interesting poster on that. I don't know, I thought.
One thing traditionally when we talk about patient-generated data in personal health records, there's always this discussion about physicians, especially being resistant to this. But I'd like to point out that the entire patient history is patient-generated data. Mm-hmm. And when somebody comes in and sits in front of you and talks about the medical problem that they're having, which forms the framework and the backbone of the encounter and of what is documented in the electronic health record, all of that is patient-generated. And so really, to me, as a physician, there's not that much of a stretch in allowing patients to have access to their records and contributing to it when they've already contributed such a substantial component of their history already.
And, and I would take it even a step further to say that when we take the patient's history, we're attributing our own biases in that story itself. And if, the patient can give the exact same story, but the 5 different physicians might write it down 5 different ways based on their own impressions, based on their own stories. And so I think, I've kind of been doing a little bit of research into PHRs, and one of the things that has more validity tends to be that subjective nature of people entering their symptoms and describing those things. And even certain objective things like their weight, their blood pressure could be entered with some validity. And so, yeah, kind of going off that. Anything else? Okay, thank you.